everyone. Sorry, I'm looking at two monitors, so if you see me go back and forth, that's what it is. This is an incredible panel. I'm going to go ahead and start sharing my screen. And give me one moment. All right, so hopefully we are looking at, yeah, it seems like we're looking at the presenter view, or the audience view, not the presenter view. So we got a great talk today. We're going to talk about phases of surgical care for laryngotracheoplasty patients. I want to thank the committee for the opportunity to be here and present this discussion. We have an incredible panel. These are all people that you know, myself, Dr. Lin, Dr. Dayal Khan. Everyone here is very involved in airway and complex airway, laryngotracheal reconstruction, laryngotracheoplasties. So this is going to be a really good talk. Dr. Dayal Khan, he goes by Sandro. He's the director of the Center for Voice of Pediatric Disorders. He's also the medical director for the complex airway unit at Cincinnati Children's and University of Cincinnati.
Excuse me, Dr. Romain. Dr. Romain, you're sharing the presenter view.
Oh, okay. Let me swap screens. Is that better?
Perfect.
Okay. You can see the future slides. Okay, so Dr. Lin is the surgical director of the Ambulatory Surgery Centers. She's the president of the medical staff. She's in the Department of Pediatric Laryngology at Nationwide Children's Hospital. I believe that is the Ohio State University. And associate professor of, associate clinical professor of otolaryngology. And then I am Romain Johnson. I'm the medical director of the Children's Health Airway Management Program. I'm at Children's Medical Center in Dallas, and I'm an associate professor at UT Southwestern, also in Dallas. So I think about this quote a lot, and those of you who know me and have heard me giving talks before, you'll see this quote mentioned quite a bit. And it says the means represent the ideal in the making and the end in process. And obviously Dr. King was talking about politics, but I think it also applies to quality and improvement. When you think about, do you want to make things better? You want to improve your quality. You have to think about the processes by which you achieve that end. But they're interconnected, right? You have to choose the right ends in order to create the right processes, and you have to have the right processes in order to get to the right ends. So I go through this a lot, and that's going to be a big part of this talk. What are the means to the ends that we're trying to achieve? The other thing that I talk about quite a bit is, this quote from Mark Twain where he says, "My books are water, those of great geniuses are wine. Everybody drinks water." And, I did my fellowship at Cincinnati, and obviously I was surrounded by geniuses. And during my time there, I realized okay, I'm not a genius. I'm probably not going to innovate the way they innovated at Cincinnati, but I can learn the processes to do a competent and proficient LTP consistently. And let me focus on that. Let me also recognize what are the steps involved for the workup? What do you do intra-op if you run into problems? And how do you manage the patient post-op and long-term? Let me really focus in on those processes. And I hope this talk is also geared towards that. Obviously, we'll have great geniuses giving presentations, but my idea is this is water, not wine. And so I'm the de facto quality improvement person at Children's Medical Center Dallas for the Department of Otolaryngology. And as a result, I'm constantly looking for new information in order to be more like water. And a few years ago, the American College of Surgeons came up with this idea of phases of surgical care. And it was a quality improvement initiative, and they really wanted to address surgical quality across the care continuum: preoperative, perioperative, intraoperative, postoperative, post-discharge. All of those things matter. Let's figure out a way to connect them so we can take better care of patients. And these are just some of the examples of the process outcomes and quality. What is your surgical plan? How do you identify comorbidities? What are prevention and screening that you can do ahead of time to make sure the patient is healthy overall? How do you communicate risk to families? How do you make your care family-centered? Do you belong to a registry? What do you do during your surgical timeout and your surgical debriefing? Et cetera, et cetera. And I really hope you go to the American College's website and look up phases of surgical measures, and you can read about their efforts, which brings us to laryngotracheoplasty. This really, our laryngotracheal reconstruction, depending on where you trained. It really is the cornerstone for patients with severe laryngotracheal stenosis. And the approaches to management involve more than just the procedure itself, right? It really involves all the phases of surgical care. You have to select the right patients. You really need multidisciplinary evaluation. There's a lot of intraoperative decision-making. And then how do you do postoperative communication and interventions? So at the end of this seminar, I hope that we'll describe sort of the optimal workup for LTP patients. We'll identify some of the and develop some of the protocols that you can use to manage complications as well as salvage techniques. And then maybe towards the end, we'll talk about safe processes to decannulation. And so I think I changed the slides around, and so I accidentally deleted Dr. Lynn's slide, but Dr. Lynn is going to go next. Her introduction, I just had her picture again. So I'm going to stop sharing and I'm going to allow her to go next. And also, let me make a quick announcement. Dr. Alessandro is apparently stuck in a case, and so he's going to try to join us. If not, we'll move forward without him.
Good morning, everyone. I'm going to go ahead and share my screen. Hopefully you all can see my slides. I'm going to assume that you can unless I hear otherwise. So I want to thank Romain and Alessandro for having me as part of this panel. I think originally my partner Chris Jotana was going to be doing the panel, and he asked me to step in. So I appreciate you guys letting me speak this morning. And I'm going to be talking about kind of patient selection and preparation for laryngotracheoplasty, the things that we can do preoperatively to hopefully ensure success for our laryngotracheoplasty patients. So I think that really this is a key, and you know, as much as the surgery and the post-op care, selecting the correct patients for laryngotracheoplasty is really important as far as the success of the procedure. So we want to make sure they're medically stable, that they're sort of optimized in all ways, because many of these patients are complex and have medical comorbidities that are going to affect a patient's readiness for surgery. And so, you know, trying to make sure that we're looking at all of those things ahead of time so that we're not dealing with them sort of retroactively. And this picture makes me happy, so I included it. This is one of my little patients who actually just came in last week for decannulation after a long time. So I thought I'd include that today. So I think the first thing to really think about when we're thinking about laryngotracheoplasty is, what are our goals for this procedure? When I think back on the patients that I've operated on with this procedure, I kind of put them into 3 different buckets as far as what our goals are. One group of patients may be that we're just trying to improve their airway enough to give them sort of a safe airway that they can go home with a tracheostomy. You know, these are the patients with grade 4 subglottic stenosis who are pretty medically unstable, or really severe stenosis that just don't have an upper airway at all. Another group of patients might be patients that we're planning a staged laryngotracheoplasty. So, you know, a multiple double stage or multiple stage, not planning on decannulating immediately, but decannulating once things have stabilized. And a third group of patients would be our single stage laryngotracheoplasty patients who we're going to decannulate or maybe don't have a trach at all. And so knowing what your goals are, I think, is really important. And then also critically important is communicating those goals and expectations to the families. So this is really going to depend on a lot of things: patient factors, family factors, social factors, medical system factors. But making sure the families understand, we're going to do this big surgery, but your child's still going to have a trach when they wake up. And we might have to do a couple more procedures to dilate or clean up granulation tissue before we're ready to get the trach out. And I find that as long as we're upfront with that at the beginning, families really do fine and sort of are along for the ride. But I think if you're not clear about those things and they think it's going to be a really simple and straightforward process, they may be disappointed. Another thing that I think is really critically important in the pre-op planning and management of laryngotracheoplasty patients is the involvement of a multidisciplinary treatment team. The majority of patients with subglottic stenosis have multiple other active medical comorbidities, about 68% of patients in this study from DC. Many of them have pulmonary conditions, cardiac conditions, neurologic conditions, history of extreme prematurity. And in several studies, the presence of pulmonary and cardiac comorbidities extend the time to decannulation. Reflux as well can be a real problem, and we'll talk about that a bit more later. But again, you know, sort of teeing up these things, making sure that we're optimizing these conditions is going to help. I think an aerodigestive team really helps with this process. Having the involvement of, you know, multiple team members in the pre-op planning of these complex patients can make sure that, you know, that we're sort of optimizing care, that we are condensing care as much as possible. There's certainly lots of studies that show the benefit, and I know I'm preaching to the choir in this group, the benefit as far as cost and time to complete evaluations. And I think as well, the time to speeds up the time for readiness to laryngotracheoplasty and or decannulation. So our airway aerodigestive team really works together to, you know, sort of wean patients off the ventilator as tolerated, wean from supplemental oxygen, at least to show improvement in chronic lung disease, and that, you know, perhaps the trache's no longer needed for things like pulmonary toilet as well as respiratory support. Many of our children, like we said, have congenital cardiac conditions, and so we want to make sure that they are sufficiently treated or improved to allow for the stress of lung surgery, recovery, you know, perhaps sedation and things like that in the ICU postoperatively. Ongoing pulmonary hypertension is, if so, is it again sufficiently improved that they're not on long-term medications? And then what's the nutritional status and what's the reflux status? So are they eating by mouth? Are they tolerating tube feeds without frequent emesis or signs of aspiration, frequent illnesses, things like that? I think those things, again, indicate readiness to a big procedure like this. And so then I think the other piece of this puzzle is identifying things that are going to be present within the patient that are going to contribute to failure of the goals of our procedure, and identifying those things and mitigating them as much as possible preoperatively. So the first thing I wanted to talk about is MRSA. So we know that MRSA colonization is common in hospitalized and frequently hospitalized patients, chronically ill patients, seems to be even higher in patients who are undergoing airway surgery. So out of Cincinnati, about 32% of patients undergoing airway surgery were found to have methicillin-resistant staph. This is higher than the general population and higher than patients undergoing other types of surgery. Things like prematurity, NICU stay, and tracheostomy all increase the risk as well. And if this is treated preoperatively, it was found to have good outcome with no infection or graft loss postoperatively. And the reason that this is important is that it's thought that bacterial colonization of stents and tubes can increase granulation tissue formation. And Staph aureus has especially been associated with this. So screening for MRSA preoperatively and treating if necessary. Reflux as well is present in a large portion of our pediatric patients undergoing laryngotracheoplasty. This is significantly associated in several studies with delayed extubation in patients who are undergoing single-stage LTP and failure of ultimate decannulation in patients undergoing double-stage LTP. It can lead to increased surgical site inflammation and scarring. This group that has looked at sort of acid and the airway in animal models like rabbits and rats has shown increased inflammation and cartilage necrosis in rabbits who had laryngotracheoplasty and then were irrigated with acid and pepsin. So definitely something to think about. Again, trying to screen for it, evaluate for it, and treat if necessary. Likewise, eosinophilic esophagitis seems to be associated with concerns with the airway. Airway symptoms are very common in patients with eosinophilic esophagitis, including cough, hoarseness, and asthma. A pretty high proportion of patients in one study of patients with EOE were found to have had a history of tracheostomy 14% and subglottic stenosis 10%, which I think is pretty remarkable, and definitely something to sort of think about in the reverse. You know, are our patients, do we need to look for this in patients with subglottic stenosis and trach? Additionally, at Vanderbilt, they did some biopsies of the post-arytenoid or the interarytenoid area in patients who were undergoing airway evaluation, and 10% of their patients with aerodigestive dysfunction were found to have eosinophilic inflammation of the larynx as well. So that may be sort of what the tie-in is, at least in some of these patients. But again, understanding if this is present and treating it as much as possible prior to, surgical intervention is helpful. Additionally, swallowing concerns. So do these patients may aspirate or, have other nutritional and dysphagia concerns related to their chronic medical condition, their history of intubation. Many of these kids have oral aversion and aren't eating. Many of them may have, things like vocal cord paresis or other things that make them a setup for aspiration. And so this is something that I think as well is really important to identify prior to any surgical intervention. If they have severe and chronic aspiration, it may be a sign that the trach is still going to be needed, or at least something to think about for things like pulmonary toilet. Additionally, aspiration may increase the risk for post-op infection, inflammation, cough, pneumonia, things like that can land the patient back in the hospital. And I think just knowing about this ahead of time, so that post-operatively, are we going to need a long-term feeding tube? Do we need to at least plan for an NG tube until the child is recovered, or an NJ tube? Post-pyloric feeds could be something to consider for patients that have aspiration and reflux concerns. And then, just again, sort of counseling families and patients on if there are swallowing problems preoperatively, that may be worse postoperatively, doing things like posterior expansions on patients with vocal cord paralysis. I think at least it's important for patients to understand, families to understand that there could be a risk of aspiration postoperatively from those types of procedures. And then see if my video will play. Not wanting to be the person that misses a bilateral vocal fold paralysis. This is something that I think, many of our patients that are going to undergo airway reconstruction, we followed for a very long time since they were perhaps intubated in the NICU. And did we ever evaluate vocal cord mobility? Did we ever do that? If so, it may have been a long time ago. And so making sure that vocal cord mobility is present, or if it's not, sort of understanding what the implications of that are going to be if you're looking towards laryngotracheoplasty. And then finally, I wanted to include this systematic approach to preoperative LTP patients. I really liked this approach a lot. I think that, putting together all these pieces, this is what many of us do, at least in certain patients in certain ways. But out of Pittsburgh, they're doing this systematic or structured evaluation for all their patients preoperatively. They're getting GI involved to evaluate for things like reflux and EOE. Again, making sure pulmonary is involved and that chronic lung disease is improving, assessing swallow preoperatively, so making sure that there's not aspiration, or if there is, understanding what the implications of that are going to be, and then screening with both nasal and tracheal swabs for MRSA, and if present, treating with topical Bactroban in the nose and with systemic Bactrim for 3 weeks prior to surgery to make sure that that's not going to be a consideration. So I just thought this was a really nice way to put all of this together and thinking about preoperative evaluation for patients. And then one final thing that I just wanted to sort of throw out there, and I'm interested for the other panelists or anyone else, is this sort of active or red larynx. This is one of my white whales, I guess, when it comes to these airway patients. And again, even just thinking about discharging NICU patients in a safe way. These kiddos who have this just chronic subglottic inflammation, you can see the infraglottic edema and erythema here. This is this patient's subglottic airway, and they always dilate really nicely. This tends to be sort of soft inflammation, but I think, you know, it just kind of comes back almost immediately. I've struggled with these. Often they don't seem to respond to reflux treatment or antibiotics or any of the sort of other things that we think about. And it just seems like it takes a really long time for that inflammation to improve. So I just thought I'd throw that out there as one of those really tough management problems. And that's all I have. I'm happy to answer any questions, and I'm going to stop sharing for now.
Thank you, Dr. Lynn. That was incredible. I think we can go till 10, right? So we'll try to, I have some ideas about some of the things that you brought up, and we'll bring it up in discussion. But in the meantime, we're going to let Dr. Dale Khan give his talk, because I see he's busy in the OR in between cases.
Yeah, I may be quick because they're already calling me, so I'll try to get through this quickly and let's you get to some cases. So again, thank you for allowing me to present today. And so I'm going to try to cover, you know, a lot of ground in a short amount of time. So hopefully, so we're going to try to cover some of the aspects of intraoperative decision making and salvaging when things go wrong. So my disclosures, I do have an R01 for voice, which is not related to this topic today. And then we will talk a little bit of off-label use of Ciprodex. So kind of a general overview, we're going to talk a little bit about LTR types, graft materials, and stenting, how many grafts, anterior versus anterior posterior, single and double staging, post-op follow-up, and then salvaging some common issues that people can encounter. So when we think about augmentation grafting, you have to remember that the aim is to expand the laryngotracheal exoskeleton. And so it tends to be a great operation for type 1 and type 2, you know, grade subglottic stenosis from the Cotton-Meyer grading scale. You can do grade 3s and grade 4s, but your outcomes are going to change based on that. And those operations can include lots of little variations, and that's really related to the pathology that you're dealing with. So we're going to get to a little bit of that later. And these are just some nice animations that we performed, mostly actually for our families to understand exactly what we're doing, so that they can look them up on YouTube. And it makes it a really nice way for them to understand what you are doing in terms of your operation. So augmentation grafting, it's really a two-dimensional operation. So it's a lot less specific or surgeon dependent. So it's easy to teach. It's also easy for people to learn and do. It's really important to remember that your outcomes are primarily related to your grade of stenosis. So the success can be anywhere from 50 to 90%, and your success is going to drop as you go from lower grade to higher grade. So your high grade 3s and high grade 4s are going to have much lower success rate with just grafting. And so that's where, you really need to start thinking about alternatives. So CTR, resection slide, for higher grade stenoses, to have those as potentially in your armamentarium of surgical treatment. You've already heard about some of the other negative predictors of surgery. So graft materials. So really the workhorse is costal cartilage. It's the one that we use primarily for almost all of our reconstructions. There are some very specific cases where you can use thyroid atlas cartilage or auricular cartilage. Those cartilages tend to be, one, smaller, and then two, like less structurally malleable. So they're harder to kind of shape to your needs. Other things that people have used are listed here, but really the one that everybody tends to usually live off of is costal cartilage, and you can get a lot of it, right? So there's a lot to be used. So important pieces too to know when we talk about LTR versus CTR. They're both operations that can be used for airway reconstruction and subglottic stenosis. When we talk about extended CTR, that means adding a posterior graft or something else. Really, the main reason to have this here is for you to remember that as you're contemplating decision-making for your patients, that if they're a grade 3 or grade 4 subglottic stenosis, you need to be thinking about this as a potential option for that patient as well. It is not uncommon sometimes for us, if we're not quite sure which one we're going to do, that we may plan intraoperatively to do one or the other based on what we find. Stenting options. So again, this is getting a little bit towards staging at some point, but also thinking about what are you going to use to hold everything open. You can do no stent, you can single stage and extubate on the table, which is for really sort of very mild subglottic stenosis. You can put in an endotracheal tube for a defined period of time from anywhere from 5 days to 7 to 10 days as your stent, a T-tube, a stent, or a wired stent, which honestly is sort of antiquated and something that we really don't do anymore. Suprastomal stent, so this is really the workhorse for double stages. It's a soft silicone that's placed in the airway, sutured in place. It has different caps that you can place to fenestrated or non-fenestrated, and this is available from Boston Scientific. In a pinch, you can use the cutoff end of a T-tube and oversew it. So important to remember too, when we talk a little bit about management strategies for double stage stent removal, regardless of the stent type, we tend to use at Cincinnati quad therapy, which is they get an MLB 1 week after their stent removal, but starting about 3 days before, they start with something to actually help with reducing granulation tissue and edema. You have to remember, when you take out the stent, you don't really care what it looks like that day. You care about a week later. Because they can often look great and look terrible a week later, and vice versa. And then for your quad therapy, this is what we typically use at Cincinnati, which you started about 3 days prior to stent removal. It's Ciprodex down the trach, Augmentin or a similar antibiotic. If they are MRSA positive, you're going to treat that instead. Decadron and a PPI for 6 months. So how long do you stent when you're thinking about your operations? So we actually looked at our outcomes when we looked at short versus long-term stenting, and really saw that long-term stenting tended to do better, and that's greater than 3 weeks. And so typically for a double stage, you're going to, at a minimum, think about 21 days, but more typically 4 to 6 weeks. So getting towards your staging pieces, again, thinking about single versus double staging, because there are cases where there may be an advantage to go one direction or another. And thinking along those lines, you know, a single stage is nice because you remove everything all at once. However, you have to consider a lot about the patient, like what's their pulmonary status, what ICU care do you have, and do you trust them? It's a longer hospitalization. You do have intubation and reintubation rates, as well as tracheostomy rates that can come with that, and that can be really hard on families. Relative contraindications: poor pulmonary reserve and active larynx, severe stenosis, multiple reconstructions. So again, getting back to a lot of those risk factors that were mentioned in the first talk. So, and with double staging, the advantage is you can kind of cut out some aspects of risks, and then you can really get the patient sort of quickly out of the hospital as well. So potentially a huge cost savings as well. Of note, something just to remember, laryngofissure is where you completely split the larynx through the vocal folds to get access. It can give you wonderful access to the posterior glottis. Typically, in our hands now, we rarely do this. And for airway reconstruction, typically for the posterior glottis, you can actually access it without having to do this. The disadvantages of this particular technique, although I have done it and still use it as a part of your armamentarium, is that you can destabilize the laryngeal complex, you can get webbing, you can get asymmetric cords, and then long-term, it's an avenue potentially for that graft to grow up into the larynx as the child grows, so it can be a cause of late complications. So anterior grafting, really simple. It's really best for grade 1 and grade 2 subglottic stenosis that's isolated anteriorly. Great operation. You can use it also for suprastomal collapse. You can do it as a single stage versus you potentially even can extubate on the table for a really mild case. AP grafting is really reserved for grade 3 and grade 4 stenosis. For these patients, if you're going to single stage them, they're going to be intubated for 7 to 10 days for stability of the posterior graft. Stenting can be, like I said, 8 weeks or longer potentially. It's good for lateral shelving subglottic stenosis. And it's especially good if you have to go up to the vocal folds where you actually have to stent open the vocal folds. And again, this is a really nice illustration of an animation of what this operation potentially looks like. Again, taking out a lot of the steps of the technical components, and great for kind of showing families what the goal is and how you're doing things. Post-op follow-up, again, some simple breakdowns of thinking about how you manage these patients. So for single stages, your plans of when you look at them again, which is really crucial. We usually think about it as almost a doubling of time based on the endoscopic view, meaning you're going to alter what you do based on what you see. So on best case scenario, you may do 1 week, then 2 weeks, then 1 month, then 3 months, then 6 months, then 1 year. And that's if they're perfect, which is rare, right? So you're going to have little bumps in the road. We typically prep our families to be in the hospital for 3 to 4 weeks. Sometimes it's shorter than that, but at least that's a good ballpark, and you can prep them for the expectation of what that looks like. For a double stage, it's 1 week intervals times 3. Post-stent removal is a good sort of general rule. Again, you can alter that based on what you see post-op, and potentially even rapidly go towards capping and even decannulation plans. Hello? Okay, I'll be there in 1 second. All right. Double stage, again, intervals of, as I mentioned, and in hospital for anywhere for 3 days to 1 week. Common complications to think about. So air leak, this can occur if you don't have an airtight seal, and you can get infection potentially in that space. You really should think about infection when that happens. The key to trying to deal with it is you can intubate with a cuff tube distally. Sometimes that's enough. Sometimes you actually have to go back in and put in TIS-seal and resuture the graft. And again, this is the place about really thinking about infection and sending cultures and really broadening your antibiotic coverage. And this is a really mild leak that you can see just against the side of the graft. Glottic gland, again, fairly common in single stages. Really, you just can plan on steroids. You can remove it optically. You can think about post-op management with racemic, heliox, and high flow. If you can get them past that 48-hour window, they tend to actually do quite well. Secondary stenosis, again, this can be if you have prolonged intubation. Sometimes you can get a secondary posterior glottic stenosis that didn't exist before because of the tube. Again, there's management strategies that we'll get to in terms of managing this long term. So again, failure to extubate, you can think about inadequate airway, glottic edema, granulation, oversedation. Your strategies, you can downsize steroids, you can do racemic, CPAP, you can try again. We usually give people about 3 tries before we go to a trach and stent, and you convert them to a double stage. Early restenosis management, really dilation is a mainstay. Balloon size is really picked based on age appropriate size or stent size. We have a nice application that's free that's called the Airway Card that allows you to do this quite easily without having to think. Adjuncts like Ciprodex are helpful, as well as potentially dividing the scar if need be. Our protocol for dilations is every 7 to 10 days for 3 to 4. If you have to go to 5, you really have to start thinking about doing something else like a trach and a stent. Just to say thank you to our team. We have a large team of airway surgeons here, really descended from Robin Cotton, so it makes things easier when we're doing high volume and really complicated cases. And then a pitch for if you want to learn more about really complicated airway stuff. In 2022, we'll be holding a multiple conference that will involve aerodigestive airway reconstruction, dysphagia, as well as esophageal atresia. So thanks. Really a pleasure to be here, and I'm going to run, so I apologize for having to leave.
Thank you, Sandro. That was outstanding. I believe we do about 5 minutes or 10 minutes before a coffee break. Is that right?
Yeah, but you know, Romain, it's okay if you guys go over a little bit. We can always shorten the break.
All right. So I do have some, and then I think I need to swap views, right?
Looks good on our view here.
Oh, is that good? Or do I need to swap? All right.
Go back to
the other one was better.
The other one was better. Okay. So I won't spend as much time on the videos only because I have a lot. Whenever I go to these conferences, I'm usually in the audience and I'm writing all these questions down and like, oh man, I need to ask this, I need to ask this, and more for my own thinking and thinking about things in the future in terms of when I go back to my home institution. So I'm going to just start with some questions for Dr. Lin, because you said some things that I wanted to follow up on. So one of the things is, so you have an aerodigestive team. Do you have the members of the team follow your patients in the hospital after you do your LTP?
I guess, yes, usually, but it depends a little bit on sort of how active their ongoing problems are. Certainly, we have the PICU involved with our immediate postoperative management of these patients with, sedation and, respiratory support and things like that as needed. But yes, I would say often GI is still involved while they're in the hospital, pulmonary. We will typically get a swallowing evaluation in appropriate patients while the child's in the hospital, although that's not necessarily one of our aerodigestive speech therapists who does that. So yes, but I guess still a little bit case by case, just depending on, what's going on with the child at the time.
So not routine, more case by case.
Mm-hmm.
We do the same. I'm wondering though, if maybe I should just start doing routine, like as a part of our post-op plan, consult speech therapy, consult GI, consult pulmonary, and just get them involved early on.
Yeah.
Because sometimes we're chasing our tail after, like, oh yeah, the reflux was worse than we thought, or other things. The other thing is, the next question is, how do you assess for mucociliary clearance? One of the challenges I find is that, the family will say, oh yeah, my kid hasn't gotten sick in a year. They're great. They know how to cough. And then you do an LTP and all of a sudden they're not coughing.
Yeah. Yeah, no, that's a really great question. And I guess, again, something that I don't think that we routinely assess, other than, like you said, sort of clinically how the child's doing. Have they been admitted to the hospital? How often? I do try to get a sense of how often the family's suctioning versus, sort of letting them clear secretions on their own. But I think especially if you're contemplating a single stage reconstruction, that's, something that's hard to assess. And many of those kids have never had to cough anything out, sort of through the mouth, so that it's something they do have to figure out how to do. We'll support those kiddos sometimes with, vest therapies or, just manual chest PT, just to sort of help move stuff and clear it, nebs if necessary, which I think is helpful. But
do you think that's okay? I often get phone calls where they'll say, hey, is it okay if we do CPT or cough assist? Do you think there's any risk to the grafts?
I mean, I guess in the first couple of days, I wouldn't have them do vest therapy, but I feel like some just, manual chest PT, especially once they're extubated, is reasonable to do.
So this is a kid recently, so 3-year-old, she has Turner syndrome. She had a coarctation repair, 6 months old, and she's obviously out the hospital, no trach. And the family comes and says she keeps getting pneumonia and she has significant stridor with exertion. And so she's got a tracheal stenosis, pretty high, maybe second, third ring. Mm-hmm. What are your thoughts in terms of preoperative workup, decision-making?
Well, so with the recurrent pneumonias, I would definitely obviously want to look at vocal cord mobility and get a swallow assessment to see. I mean, obviously that may be just related to sort of secretion clearance issues with that segment. I mean, it doesn't look terrible to me, to be honest with you, the tracheal stenosis. And with this view, I mean, seeing that arytenoid prolapse, I wonder if that's not contributing more to, and vocal cord immobility, if that's not contributing more to her symptoms than the tracheal stenosis is.
Yeah, those are good points. I kind of thought the same thing. My other additional issue was, it seems very reactive, like it bleeds very easily.
Yeah.
This is obviously an injury from, 2.5 years ago, and it's still bleeding a lot. So, we obviously did a multidisciplinary evaluation, a triple scope, culture. She did have the flexible exam was tough, to say the least. But it looked like the left vocal cord was out. It didn't look like she was aspirating. We did a swallow study and that was normal. She didn't have reflux. She didn't have a lot of other findings on her triple scope. So how does the vocal cord paralysis affect your decision making?
Yeah, I mean, again, I think that at least, is a risk factor for post-op aspiration, depending on what you decide to do. And I had these kids too, where the flex scope's really difficult in the office. And sometimes I'll do a flex scope in the OR with our triple scope with like a little bit of Versed or sedation, which seems to help a little bit and hopefully doesn't affect, vocal cord mobility too much. I mean, I think it absolutely does. And again, I feel like that arytenoid, sort of what we were seeing with the arytenoid there, I might consider addressing that first before I did anything open airway. But obviously that may set her up for more aspiration too, if you, do a partial arytenoidectomy there.
Yeah, it was a tough case. I did all those things you suggested and she was still having symptoms. So eventually I did a tracheal resection, and she's doing better from a breathing standpoint, but she still is getting lower respiratory tract infection. So I think, the aspiration was probably more of a risk. We couldn't pick it up. Yeah. Do you think that the BALs are good at picking up aspiration? I do it a lot. And
look for lipid-laden macrophages and I mean, I guess it's the best that we have to look for sort of chronic aspiration, and it seems to correlate, I guess, to me, but how much that, like if it's not there, I guess, can you rule it out? I don't know the answer to that.
I'm looking for answers, Dr. Lee. All right, so, let me see, there was some, let me see if there are any other questions that I had that you can answer. Interesting. Now, do you do the same approach for the MRSA? Do you treat them with Bactroban and Bactrim for 3 weeks before the surgery?
Bactrim, yes, but I hadn't been doing Bactroban, but I like that. So I think I'll add that, and seems like a low risk thing to do, and why not?
They also mentioned, or Sandra also mentioned, that he gives them antibiotics 1 week before they take the stent out. Honestly, I keep them on antibiotics until I take the stent out. I just find the infection rates very high if you leave a stent in with no antibiotics. What is your approach? Yeah, I typically will do the week before, but I hadn't been doing the Ciprodex, which actually we had a former Cincinnati fellow just join us, and so she told me about that, and we've started doing that now, but I hadn't been doing that before, but I like that idea too. I guess, yeah. And so, all right, so this is a patient who had born with congenital subglottic stenosis and laryngotracheal anterior glottic web. And I chose to do a LTP first and then address the web second with an endoscopic approach. And so I took the stent out, and this is about 2 weeks later. And this is what I find. Let me see if it goes a little bit faster. What are your thoughts here? If you start to see everything looks very reactive, the lumen's completely shut. That's what I want you to tell me. I hate these. I just feel like you do these $1 million workups and you never find anything. And, one thing I do sometimes with these kiddos is anti-inflammatory dosing of azithromycin, like the Monday, Wednesday, Friday low dosing. And I've had success with that, but it's after months of treatment. And so I just wonder if it's really successful treatment with the azithro, or if they just finally had, their inflammation finally settled down. But these are like, I feel like I get 2 of these a year, and they're sort of the bane of my existence. And yeah, you feel like you can't really do any kind of augmentation, laryngotracheoplasty on these until that inflammation settles down. I'll typically,
take them back to the OR sort of every 4 to 6 weeks just to dilate, so that, because I don't want it to turn into a stage 4. But I don't know if that's contributing to the inflammation, and, you know, sort of what the right interval is for doing that either.
So I put them on so all my LTPs now, I just say, when we take the stent out, the first look is 2 weeks,
Mm-hmm.
and we're gonna dilate. And I just tell all the families, there's going to be a lot of swelling, there's going to be granulation tissue, and we're just going to dilate. And then I schedule them for 2 weeks after that. The moment I schedule my surgery, I schedule the open procedure, and then I schedule like the next 4 procedures. Mm-hmm. And then if I do 2 weeks instead of a week, that was interesting that they bring them back so often. I have challenges just bringing them back, coming back in 2 weeks.
Yeah.
I'll bring them. I brought her back again in 2 weeks, did another dilation, and I use mitomycin C now for all my cases. I don't know if it works, but it's just like the Ciprodex, right? You just, it's a habit that you do. And so I do Ciprodex, mitomycin C. And so that's what I did for her. I just did multiple dilations, and I was able to eventually, things settled down, and we actually decannulated her. All right, let me just answer a couple of questions in the chat, and then we'll get out of here. How long do you give the quad therapy for? So, you know, that was Dr. De Khan's thing. I thought it was 6 months. Oh, these talks are being recorded, so you can go back and listen to them. So it was like 6 months of the Prevacid, and then I think it was like a week of the Ciprodex, something like that. But you can go back and listen to the talk.
Yeah, I didn't catch. I know he said they start a week before, but I didn't, or 3 days before that second bronch, but I didn't catch how long they continue those either.
Yeah,
so
I think actually they may stop the day of the procedure, but they continue the reflux medicine. But anyway, it's recorded. You can go back and listen. And he also had his email address on his slide, so you can email him directly. And then, do you consider injecting Kenalog with balloon dilation? Also, are we supposed to take deep tissue biopsies in such edema? So I don't do the biopsies. I will do Kenalog injection, but a case-by-case basis. If I think that it'll help, primarily I use mitomycin C with dilations as my primary approach. If I'm reaching the point where I'm thinking I have to do something else, I'm talking to the family about putting a T-tube in or putting a suprastomal stent back in. I personally, if they're old enough, I like to put the T-tube in. I think it provides better stenting because I'm going to leave that thing in for 3 months now. I'm not going to just put it in for another month. I tend to be aggressive because the data suggests if you need the stent, try to stent even longer.
Yeah. I actually do use Kenalog pretty frequently with dilation. We have trouble getting mitomycin C at our institution. They kind of stopped having it easily available. So I typically will inject Kenalog instead after I dilate those kiddos. Again, I don't know how much it helps.
I'm going to ask just one more question, Dr. Lin. Capped or 24-hour or 48-hour capping trials or capped sleep studies?
I typically do have my kids start once they're capping all day when awake, I get a cap sleep study. Then I just bring them in for one night to decannulate, have them on pulse ox, and let them go home the next day if they do find that first night.
All right, so there's a couple more. We've run all of our LTR patients through aerodigestic clinic and typically a triple scope prior to surgery. Yeah. So yeah, we do the same. And I have a checklist now in Epic. So I'll go and I'll check the list in Epic to see if we did all the things we're supposed to do, because I'm surprised sometimes like a week before surgery. We also now have an airway conference where we sit down and have a lunch where we talk about the patients that we did the previous week and then the patients that are coming up in the next week. And we go through all the airway patients to kind of watch videos and basically make sure that we're bouncing ideas off of each other and that we're all on the same page. And then Dr. Ankasuan, she's going to kill me for that. But she said, consider laryngeal ultrasound for difficult mobility evaluations. Yeah, that's a good point. But she's very talented, Doctor. You know, you're very talented with the ultrasound, Faye. I don't know how to do that, and I don't have one in my clinic. But yes, maybe we ought to do that more often. And then kinalog injection. All right, said let's do a wrap. Okay, guys. Oh, do you downsize before the cap sleep study? Sometimes yes, sometimes no. It just
Agreed.
depends on.
Depending on
I
how.
don't like anything lower than a 3.0 because they mucus plug and it's just a hassle.
Yep.
All right. Hey, thank you so much. You're awesome. I hope everyone is safe. See you all soon.
Yep. Thanks for having us.